Welcome, everyone, to this episode of Freedom Hub's Free Market Cash Patient. I'm your host, Jeff Cantor, along with my co-host, Charles Froman. We're excited that you're here tonight. We are being sponsored by the Marketplace for Health, Wealth, and Freedom, which is found at your-mp.com, and we definitely are the disruptors intersection, as we'll see yet again tonight. The problem is out there, and for most people, they themselves know what it is. You can kind of put any number of names, could be government or what have you, on this individual in the center, but we've got a problem, and there's only one way to fix it. We got to get everybody else out of that equation but the doctor and the patient. And then also information. Where are you going to go? Now they want us heard, depending on when you're hearing this, now they want the government to be able to stop places like Facebook or Twitter from having things on there, even texts that they don't necessarily think is viable. Well, who gave them permission to decide what's accurate? Usually through science, you think something's right and then you figure out you're wrong. So you got to get all the info out there. In that same vein, we run a show also earlier in the day. This has to do with more broader freedom issues like 5G and vaccines and water and all sorts of other things that attack you both personally and physically. So be aware of that and definitely take a look-see. And then again, everything's at the main site. So just to give you a flavor of where that's at, if you get over there, there's a boatload of drop downs. Let's take a quick tour just so you're aware of everything. On the home tab is webinars. That's why we're here. Then more importantly, the continuing the conversation, because if you click on that, what you'll discover is after the call is over, whoever we had on that particular week, and this goes back for years. So there's a lot of great stuff, current as yesterday, some of this stuff, sadly. But you'll be able to connect with these people and help further the cause or get involved or use our services or any number of things that are appropriate. Under the Freedom tab, we've got Fighting for Freedom. This is another important area. Why? There's all these issues that are happening you need to be aware of. You want to get your John Hancock on here. And then also the different kind of groups that are helping fight for freedom from one end to the other, from your financial freedom, your personal freedoms, your health freedoms. They're all important. So this is another area to be aware of. But the reason we're here today is the webinars. So on that tab, when you click on that, you get to the homepage, a little info at the top about what we're doing, a breakout of the 2 interviews of the day, and you'll see about where we're at today. And then also, if you come down, a nice rundown on who's coming up, so you can kind of plan ahead because there's going to be a killer topic or you want to invite some friends to be on it. And then here's the real important part. This is the links to all of the places that this lives after today. So after you see it, you'll click on, say, Brighteon as a perfect example. And over here, you'll discover there's a whole wealth of these events from over the years. There's some really very good ones. And like I said, sadly, you can go back 2 years, and this is important as what we're going to hear about tonight. And some of these problems are going to take a long time to fix, which is why we want you to help further it by continuing the education or spreading these videos around for others to see. So on that good note, let's find out what's in store for us today. And Charles, why don't you do that honors?
Gladly, Jeff. And Dr. Prasad, it's really good to have you back. And I say that because it wasn't too long ago that he presented here on Freedom Hub regarding what I call his surgical filter. And to me and those really in the health disruptive space, that's a huge phrase because while so many folks are excited about transparency, what's really hard, and people know this, is choosing the right specialist, getting the right surgeon when you need an acute intervention. There are rating platforms out there that tell you, like Blue Book, who the better surgeons are, who the better hospitals are, what the hospital is known for. But they each, as well intended as they are, as helpful as they are, the better than nothing. They all have flaws. And Jeff and I and everyone on this call have seen lots of entrepreneurs trying to crack this nut. And a lot of people think Sanjay has, the best state of the art answer here. And for him, it's a big deal. It's not about making money or just getting people to the right surgeon when they need it, because it's also about avoiding unnecessary surgery. But Sanjay has a new book out where everyone is kind of focused on this post-COVID reset, how to build back better. And he has a book too on making sure that the post-COVID healthcare system tries at least to fix this surgical quality problem. And one of the motivating factors for this book is the fact that a lot of the victims of improper or unjustified surgery have been underserved folks, minorities, people without the resources and whatever to help them get the right surgery. So they end up getting too much surgery or really bad cases of it. So this is a big calling, not just to fix the discrete problem of quality, how to find, how to access it, but how to really protect the vulnerable from some of the victimization that has happened because of the lack of quality when it comes to the really more intense interventions in our healthcare system. So that's the introduction, Jeff.
Okay, excellent. Well, I'm going to cease sharing my screen and I'm going to give Sanjay control there.
Yeah, thank
Okay,
you so much, Jeff and Charles. Again, a real pleasure, real honor to be, number one part of your group. I'm very honored, and we're obviously very passionate about what we're doing. Look, I've been a practicing surgeon for 30 years, and we know the healthcare system is not working, and it's not working on behalf of patients. And a SurgiQuality is really an effort to try to fix that referral system that I think that is so flawed. And and our mantra is know before you go, empowering patients with better information. And in today's world, patients develop a condition, they end up with a primary care doc, and before you know it, they've seen a surgeon, they've been recommended surgery, and that bond has already formed, right? And it's very hard. In today's world, it's very hard to take a patient from a surgeon that they've already seen, they've already been diagnosed, and they've been told they need surgery, and to get them to pivot. And I think there have been lots of advances with, lowering the deductibles, maybe paying them to go to other surgeons for overall less cost for the employer as well as themselves, less use of their HSA, for example. But getting the patient to pivot, I think, is one of the hardest challenges that we're going to have going forward, and nobody's really solved it yet. And I think everyone has been focused so much on price, giving the patient a financial advantage, maybe zeroing out their deductible or paying them perhaps to go to a certain surgeon. And they've kind of brushed aside this whole idea of quality. And this is where I think our platform comes in. And we used to call ourselves SurgiPrice, and we remarketed to SurgiQuality because that's where the deficiencies are, I think. And today, patients are referred from their primary care doc to surgeons. Not a lot of thought about the cost of care, not a lot of thought about the best outcomes for that condition. And the result is this. Patients are getting surgery they don't need, and it's happening at an alarming rate. And so depending on specialty, 15 to 25 to 30% of surgeries are unnecessary. And so they're subjected to surgery they don't need. They're getting complications from surgery they don't need. They're getting revision surgery. They're having infections. They're ending up, staying away from work, reducing the GDP overall, and creating a real mess with their family structure, not only their family structure, but also their financial well-being. And not only that, patients are also getting referred to surgeons that don't necessarily have the best outcomes. So we're trying to solve this referral process, whether it happens from the emergency room to the surgeon or the primary care doctor to the surgeon, and we're trying to disrupt it, improve it, and maybe even form a partnership with their primary care physician, with DPC or whatever that might be, to help patients try to navigate the healthcare maze. Remember, they've been referred to one surgeon, they've got a provider book, a network of other orthopedists, for example, that they could see, and they have no way to pick their surgeon based on outcomes measures very specific to their condition. And that's where I think the market is really lacking. And our solution is really this, is to a concierge service. This is not novel. This a lot of solutions are using a concierge service, but we've created the HIPAA compliant SaaS distribution platform to once we access their medical records, their imaging, and to distribute it to multiple surgeons within their network or beyond. The surgeons get pinged if they're in their area of interest, and the surgeons review the case, and it can be on the app or iPad or whatever have you. They validate necessity, and if it's not necessary, they also indicate alternatives to surgery, and they also put in their metrics, which is so important. That is success measures, how many cases they've done the previous year, success measures and complication measures, but very specific to the condition. And that's where I think the market is lacking. And the market is demanding corroborated data, not self-reported data. So it's the market that's asking for corroborated data. So we're taking that information that they give us, a volume, success measures, complication measures. We're helping them corroborate it against their medical record with CPT codes and ICD codes, and then comparing the cohort of surgeons that are reporting and assigning a star grade. And then the patients are the drivers. They end up going wherever they want to go. But now we've got a way of getting quality transparency in the hands of the patient. And if they don't understand, the outcomes measures, our concierge is there to help them the entire way. And this is the platform, the patient dashboard. They can look at various surgeons that have opined on their case. And now for the first time, they not only get deductible lowering options through price competition, but they're also able to pick and choose their surgeon based on these star grades. And remember, we're looking at very specifically at success measures and complication measures. And I'm going to show you some examples of that in just a minute. I won't belabor too much, but it's through this platform, there's going to be peer review of every surgical case within that specialty. And that's a good thing, because peer review is going to help eliminate this unnecessary surgery, 15 to 20%. I think it's going to be a great thing for patients. It's going to be a great thing for reducing risk for the surgery centers and reducing risk for the hospitals and reducing malpractice risk as well. So that is what we envision will happen. A patient develops a seizure. I've talked about this case before, a lesion in the brain. This patient was headed for an academic referral to have a craniotomy surgery to have that temporal lobe lesion removed. We caught this case in the middle of a holiday weekend, sent this out. Multiple surgeons reported, this is not a tumor. This is a virus. Please repeat the MRI scan. And sure enough, they repeated the MRI scan. The lesion disappeared. Tremendous savings for the patient. Tremendous savings in terms of morbidity, potential mortality, tremendous savings for the health plan. We've all had best cases like this. Not every case is going to be like this, but this is quite dramatic. And just to give you an idea of the quality measures that we're looking at, I thought I'd just run through a couple of different surgical scenarios and some quality measures that maybe you know about, maybe you don't. But colonoscopy, and it looks like a very simple operation, some simple procedure. The gastroenterologist or colorectal surgeon or general surgeon looks inside the colon for polyps and cancers and what have you. But these are the measures that we're using. We're using measures like adenoma detection rate, perforation rate, how many times they had to force through, perhaps the patient had partial colectomy surgery and there was scarring, et cetera, and the surgeon ended up going through the colon, developing peritonitis, infection, ICU stay, potential shock and potential, months and months in the ICU. That's the potential that could happen. Mortality rate. And if you don't know what adenoma detection rate is, it's the rate at which a colonoscopist finds adenomas. So this should be 20% or greater. If it's less than 20%, that means the proceduralist or that colonoscopist is just moving too fast and not looking carefully enough at the colon, at the endomucosal lesions of the colon. So these are the kinds of measures we're looking at, if that makes sense. And for laparoscopic cholecystectomy, obviously we're looking at bile duct injury rate. I was just reading about this, very interesting, how bile duct injury has happened more frequently now with laparoscopic, that is through some scopes, removal of the gallbladder, because the anatomy is difficult. You're working through a keyhole. It's still 3 per 1,000 incidents. Anybody who's doing, a lot of these cases who has more than 3 per 1,000, we would rate them poorly in the star grades. And there are going to be surgeons that are not going to report too. And I think that's all nice and fine. But the surgeon maybe this patient got referred to didn't want to report his results, and the patient's going to be left to wonder why. And we'll just leave the conversation there. And conversion rate is, something, again, it's very specific to the procedure. We're looking at how many times a surgeon, a laparoscopic surgeon, got into so much bleeding that they had to open the abdomen, get control of the bleeding, get the gallbladder out. That's conversion rate. And so we're looking at very meaningful measures for that condition. And when we're looking at cornea transplant, which is basically removing the diseased part of the cornea and replacing it with a graft, a donor graft, we're looking, and these are ophthalmologists that have come up with these measures, but 20/40 vision at 90 days, that's what they consider a good success measure, 20/40 or better at 90 days. And we're looking at graft failure rate, because once you've failed with one graft, the chances of success are not as good second time, third time, fourth time around. So it's really important. Again, the quality measures are very specific to the procedure. And when we talk about cervical disc disease, we're talking about neck cervical disc disease, and this is anterior cervical fusion, and this could be an orthopedic surgeon or a neurosurgeon who does this to fuse two adjacent vertebrae in your neck when you need to. But we're looking at, they're going from the front part of the neck back to the spine. They're traversing quite a few structures, and we're looking at laryngeal nerve injury. That is, how many times they got vocal cord paralysis from injuring that nerve, a carotid sheath injury, vertebral artery injury is possible also, because that's a major vessel that supplies blood to the brain that runs through the spine. The esophagus, the food pipe runs through that area, how often they've had esophageal injury, and then of course spinal fluid leakage. They've opened the disc and they're back there in part of the spinal cord, how many times they've nicked the dura and caused a spinal fluid leak, headaches, lumbar drain, long hospital stay, getting that thing healed up. So we're looking at measures that are very specific to the procedure at hand. And for total knee arthroplasty, and you may not even be aware of this, we're talking about quality measures like pulmonary embolism and acute myocardial infarction. And, so pulmonary embolism, the surgeon does the surgery and they can have a piece of fat that goes into the vein and ends up into the lungs and causes just a mess with perfusion, of oxygen perfusion from the lungs, or they can end up with a heart attack. And some people will say, well, this is out of the surgeon's control. We get that. But, if the precautions are taken, the rates of these should be less than the norm. So that's what we're looking at. And infection, of course, is extremely important, because who wants to take that knee implant out, wait for it to heal, and then put a spacer in, and then put another implant in there? Nobody wants to go through that revision type surgery. So, I wrote a book on this topic, and I'll just stop the screen share. But I want to switch topics to something else that's become very near and dear to me, and that is the racial disparities in healthcare. And I'm going to read you some things that might shock you. It may not shock you. I don't know. But there's a gentleman named Dr. Adel Hayder from Brigham, did an extensive meta-analysis, basically looked at the English literature and looked at racial disparities in terms of outcomes for surgery, and really reviewed the literature up until 2013. Very interesting. Maybe I can share this with you. Let me see if I can share this, the screen with you. If I can find it. Let's just go share the desktop. Can you see that? Can you see this is part of an excerpt from my editorial, and I quoted Dr. Adel Hayder and his team, and I can send you the reference, and I can send you actually the editorial, and you can look up the references if you want. But these are some astonishing findings that you guys may not be aware of, and I certainly have become more aware of. But here's a study, a nationwide study of appendectomy, gastric fundoplication. That's when you get so much gastric acid, the stomach has found its way into the thorax near the lungs, and they fix that situation, or bypass surgeries for obesity. And they found that Black patients were more likely to die in hospital than white patients. And it was pretty astonishing, 2.6 versus 1.6 per thousand. That's a pretty significant difference. And they looked also at the effect of gender on lower extremity arterial disease, and they found that females actually have increased odds of mortality than among Black patients specifically. And they found larger disparities actually in higher risk surgery. So again, we were talking about anterior cervical spine surgery. What they found was mortality, patients actually dying 1.57 times higher for Black patients than white patients. And this has been controlled for age, for insurance status, geographic region, and also for extent of disease. So this is pretty astonishing. And Black men over the age of 65 less frequently get aneurysm repair, that is abdominal aortic aneurysm repair, compared to white men, despite a higher disease prevalence amongst Black men. This is astonishing. And the racial outcome inequities, I'll just read this for you. When controlling for insurance, a study of major hepatectomy, which is liver resection, Black patients had twice the higher odds than white patients of death, mortality after surgery. And they controlled for insurance status, clinical and hospital factors. So there are some racial disparities. Black patients are treated differently than white patients. Some Black patients are referred to low volume surgeons more than high volume surgeons. How can we solve this? And I wrote this editorial because our platform is actually a solution. And so how is it a solution? Let me go back to my my slides here. Because when we capture the medical record, right, we're capturing the documents from the surgeon that said they need surgery. We're also capturing the .com images, and we're presenting the cases, but we're blinding them according to race, ethnicity, and sexual preference. So now surgeons are seeing these cases without that knowledge of race and ethnicity. Obviously, if it's clinically relevant, we'll certainly show that to them. But this is a great way to start looking at what happens with Black and white patients with different disease processes. So we're in the process of applying for a grant from the NIH, from the National Institute of Minorities and Health Disparities. It's going to be very exciting work. We're going to look at the literature research that's been done to date as our control, and we're going to look at patients as they come through. It's going to be exciting work because I think So I'm going to open it up to questions. I've been talking nonstop, and I'm happy to open it up.
That was very good. I appreciate that. You know, in talking about your last point, because there's a lot to break out there, but on that last point, you know, I can see where some of the Black or anybody that's kind of a lower income situation, they get in that trap where they just go to wherever they're told and they end up with a mediocre doc. So that takes care of, kind of cancels that a little bit. But in your situation is a good example. We know, I mean, I'm kind of a layperson, but you know, men have different issues than women. Blacks might have different than others. So is your system also screened that way too, where race or background, like certain people from European descent are more, you know, get Tay-6 or some other kind of stuff that others wouldn't get? So that little ethnic or racial aspect actually is pertinent to getting a better diagnosis, where maybe you would say, I do not want them on that med or this or that, because that whatever always has bad outcomes. Does it help filter that too?
Well, yeah, as I mentioned, you know, like Ashkenazi Jewish people have certain predilections for breast cancer, for example. So when it's clinically significant, of course, we're going to present that. But by and large, I think it's great if we can blind that. And the other thing I will tell you is that surgeons, hospitals, surgery centers look at the insurance, right? When they're making that determination of surgery or
Yeah, that too, right?
there's a
Right.
patient on Medicaid, is the patient on Medicare, does the patient have a great indemnity plan? You know, these are factors we're trying to remove, and it's going to be difficult, but I think it's good. You know, we're moving in the right direction, Jeff.
Excellent. Charles, I see your hand up.
Well, it's nice, Dr. Prasad, that you mentioned Medicaid, because I was just gonna think as you were speaking, how do we fix this with your NIH grant? And I'm impressed that when you ping your surgeons in your platform, you're hiding that the data that might give them the opportunity to refuse serving a patient like that they don't want. And I was thinking, why don't you have your platform be a vendor for Medicaid? But then you just said, well, the doctors are looking to see who's paying. Medicaid under reimburses, so they don't always have the best doctors or hospitals in network. And I was thinking, well, some of the larger employers that have large workforces, including lots of minorities, they're the ones innovating with the consultants to do direct contracting with the surgical centers, special deals with hospitals. So, I think this is not an easy question. This is not an easy answer for you. How do we get the doctors to take care of the patients despite the payer? Do we get them all on exchange plans? Everyone has the same plan, and you get rid of that the discrimination among payers. Get them all paying cash. I don't know. This is a brainstorm. I don't know.
You know, I'll tell you that if they're employed by the hospital, I don't think they really care. You know, I don't think they really care. And I don't think it really makes a difference to them. But if they're in private practice, it certainly makes a lot of difference to them. So, I think there's a difference in the mindset with surgeons that are in a hospital employed situation versus private practice. I think there just is.
Wonder also in some respects, once you kind of open it up the way you do, that sometimes they may land in a price zone that fits Medicaid anyway, or gets close enough. So that might just blindly let them get to the right place. I was going to take advantage here and put Dr. Campbell on the spot, because I want to definitely get a quick comment from you for sure.
Great presentation. I'll make one comment about the racial disparities, because it's always hard to know cause and effect. I've worked a lot with a specific disparity of outcomes in maternal care, maternal fetal care. And, what we find, first of all, is all outcomes, every complication is higher in Black women than white women. And of course, one of the predisposing risk factors is the Black female pregnant women come in often with less prenatal care, well, almost always collectively, less prenatal care, more obesity, more diabetes, more hypertension. And so they're more prone to complications. But I also did find some very interesting things about, we have a lot of drug shortages in maternal care. And I think the unhidden pearl is, if you were to go into like District of Columbia and look at one side of the Potomac River and the other side, who would be out of magnesium and Pitocin and progesterone and saline and epinephrine and Proventil? It tends to be the predominantly Black community hospitals. So, but you know, it's hard to prove cause and effect, and I don't know where that will lead you, but it is a little dicey sometimes as to explaining why these outcomes differ. And I take care of these patients in all those surgical settings you described, and I know that oftentimes the outcomes are just worse. You can stratify it. So.
Yeah, and we're trying to control for that, Dr. Campbell. So we're trying to control for, insurance. We're trying to control for socioeconomic class. And a lot of these studies that the Brigham surgeon, Dr. Hadler, brings forth are those that have had, like, he's comparing two cohorts of patients, but they have similar sorts of other factors, yet their outcomes are so different. And sometimes it's because they've just gone to a low volume surgeon. They haven't gone to a high volume, efficient, high quality surgeon. And that's how they've been referred. And so these are some things that we can start to really take a closer look at and make a real difference.
No, I love that idea. I'd like to just, I'm always looking for quality as the holy grail. And, you seem to be pursuing that. Are there other peers who are doing things similar to you or maybe different than you that you look at and say, wow, that's really has potential also?
I haven't seen anyone. Everyone's focused on these Medicare quality data, which is like so superficial. It's readmission rate. What does readmission mean to a patient? I'm not sure what that means. Did they send them out with like inadequate narcotics or, well, I mean, I don't, patients just don't know what that means. But, when you start talking about bile duct injury and you're talking about potential stenting and potential, multiple operations, whether it's endoscopic or whether it's laparoscopic to fix that bile duct, that resonates with patients. That we got to talk about measures that resonate with the patients to get them to pivot. Does that make sense to you?
Yeah, I think the cash pay model, transparency on price is obviously something that we're trying to achieve, but I don't think that's enough. I think transparency on price and quality. You can be in a metropolitan area and have the lowest price on your colonoscopies, but what are your outcomes? And I think the two have to go together. So I love what you're doing and I'd want to learn more, but we're rolling out a pretty big project and this is big new news, Jeff and Charles. We're rolling out a cash pay rollout program in Georgia, Florida, and Texas. And we're still working on the details of it, but I really am looking for that holy grail of transparency of price and quality. And the health policy experts tell me CMS has that data on quality. And they're convinced that is the holy grail. And so, but I'm looking obviously for something else.
So Dr. Campbell, my thinking, and this is my thinking, right? I know everyone's focused on cash pay. I get that, where everybody's trying to reduce the cost of healthcare. I totally get that, right? We want to lead with quality and truncate with pricing. What do I mean by that? You get everybody's quality information first, and the most expensive options, you just basically don't show to the patient. So you truncate them out. And I think that's when you get the market to move, right? And that's when you get surgeons to start looking at their quality data and trying to take, and trying to improve themselves, maybe get proctored or, take some CME class or something, some more training, additional training. Perhaps their hands aren't steady enough and they're rupturing all these aneurysms. Well, why are they doing it? You know, in my book, in Resetting Healthcare, I didn't even talk about my book. It's very interesting. You know, they had a gallbladder surgeon who was getting all these cases at an academic center from all over the country, right? But, you know, he trained at a time when, you know, gallbladders were done open. He didn't train during the laparoscopic era.
Right.
So he tried to learn laparoscopic techniques, you know, later in his life, and he wasn't all that great. So what was happening was he was getting a lot of bleeding. And in fact, anesthesia had changed their protocols. They were having the most experienced anesthesiologists in that room. They were having, these patients were being type and cross-matched for multiple units of blood. This was like unheard of for other surgeons. So they were making all these accommodations for this surgeon until a patient died. And once the patient died, then they started looking at their process. Why does it have to come to that, right? Why does it have to come to that?
No, more power to you. Thanks for everything you're doing.
Yeah. Oh, if anybody wants a copy of my book, I'm happy to send you a complimentary copy. If you just send me your mailing address, you know, I'll be happy to shoot you a copy.
Okay, perfect. I'll have you stick your email in the chat if you would.
Yeah.
That'll solve that pretty quick. Charles, I see your hand is up real quick there.
A three-parter, Sanjay, and I'll repeat the questions as you go along. You mentioned that dynamic between employed surgeons and private practice surgeons. And, you know, Jeff and I, and maybe Dr. Campbell and others, you know, we want to see a more vigorous market where hospitals face more competition with physician-owned hospitals, with different kinds of hospitals, expanded clinics. So we're definitely biased towards that end. And we like the quality filters and, you know, obviously we like what you're doing. Number one, how does that dynamic impact what you're looking at between hospital employment and independent practices vis-a-vis this disparity that's got you, you know, very concerned? And I can stop there, let you answer and go to the next question, or I can continue my other questions.
Let me finish with that. So let me just finish that question right here. You know, we went to a large academic center, very large academic center with 50 hospitals. Okay. And we were talking to their surgeons. And I was stunned by what they were telling me, right? Neurosurgery, they have an array of neurosurgeons with different levels of expertise. Some just finished their fellowship, some that have been in practice for 20 years and see a lot of pituitary tumors, and the younger guys just don't see as many, right? So they were telling me that a pituitary tumor that shows up to a low volume, early young surgeon ends up getting done by that surgeon, right? Instead of that surgeon actually referring it to one of his colleagues at the academic center that was high volume. Because, and there are other guys that do 200, 300 tumors a year. I mean, they're just, and these young surgeons coming out of their fellowship, you know, they're just starting out. They're doing 2, maybe 3 a year. So they've got issues too, and they actually want to solve the problem as well. So I think the hospitals, I think they're going to be on our side with this. I think they will. At least the academic hospital that we were talking to, you know, certainly interested. We've got some real issues with competition. You know, the hospitals have really soaked up all the surgery centers. They kind of control the market. They have a geographic presence. They're brick and mortar. They can't be moved. And, you know, but they're also interested in quality. Look, we want to reduce their risk, right? We're also trying to reduce their risk of spinal fluid leakages, of mortality, you know, surgeons that aren't doing the right thing, you know, and not getting the best outcomes. You know, that's all part of their risk too. So the conversation can be had, but it certainly has to be had, you know, in a diplomatic way, if that makes sense.
And just to continue that before the next question, What about the dynamic that we want to see in a real free market where you have physician-owned hospitals, no more certificate of need protectionism, expanded clinics that do a lot more? I mean, you can still have filters involved with those people too, using your platform, right? Your platform just can't be used in that big hospital, right?
Of course, of course. Yeah. You got to think quality first. I get your pricing and cash pay. I get all that, but it's got to be quality first because, if you've got surgeons that are doing unnecessary stuff or, we're not winning. We're not winning. We're not helping the patient. The bottom line is to help the patient, right?
Right. But my point is, you don't oppose that competition dynamic with more and more innovative competitors to the hospitals?
Not at all. Not at
Okay.
all. And our conversation to hospitals is this, Charles. It's an interesting conversation. We can get you access to cases that you are not seeing today. I mean, there are patients from all over the country that would be happy to fly in, and you could increase your volume. I mean, if you do something really well. So, and that's the conversation we need to have, right? We don't need to be antagonistic. We need to work together.
So the comparative advantage, find what you're good at and make money that way.
Yeah, of course.
Next question, what do you expect to get out of the NIH grant, assuming that goes well and has some impact and some press and attention? How will that help you take off and where will that take you?
Well, they have a couple of different phases, right? The phase 1 is a feasibility study and the phase 2 is an actual study, a clinical study. These are all clinical trials. So we're applying for a feasibility study right now. And I think that there's no question that we should get it. I mean, it's just, we just have to work through but what we want to do is to outline the problem, look at the literature in a very, very extensive, exhaustive way, okay? Identify certain surgeries, blacks and whites or Hispanics or Asians, and see where we can make an impact and use the literature as a benchmark, and then try to look at numbers of cases. And we've got a Fortune 50 company that's going to start using our platform. So we've got to have a lot of volume. And I think it's going to be exciting because as we're going to develop the feasibility study, that's great. But that phase 2 is big because now we can start to look at what's been reported in the literature and we can really do something about it. I think we can make a major impact. It's going to be very exciting.
Yeah, that gets to my comment earlier about how these big company disruptors are going to be able to use your platform to deal with some of these disparities. So that's good news. You have that Fortune 50 client. Last question, your book, I'm sure, deals with a disparity issue, the surgical quality issue. Is it focused just on that or is it more expansive?
No, the book does not focus on racial disparities in surgical care. This was something that we just kind of embarked on over the last few weeks, and we really got very excited about it because we can really make a difference. So the book doesn't address that. The book addresses the dilemma that the patients have. Right? They've been told they need surgery. They've got the surgeon. And there's all these myths that patients have about surgeons and their quality, what are they wearing, how they talk to me, how busy their waiting room is, is it marble and glass, when they walk in, is it, how busy are they? Are there diplomas on the wall? All this stuff means absolutely nothing. But this is what patients are using today, right? This is what patients are using today to assess quality. And they've got to get smarter, right? They've got to be able to look at their condition and look at quality measures, success measures, complication measures, and start to understand some of these things because it's all about outcomes.
Excellent. Thanks, Sanjay. Thanks, Jeff.
Super. I see, Bharat, you got your hand up.
Yeah, Dr. Prasad, great hearing you. I think wonderful presentation. My question is on, as the technology is improving on all sides, how is, further to your book, what you have written, and also globalization is still going to happen and happening. So how do we get the technology and globalization to play a major role in improving healthcare? In US, how do we do that? Because I have been, traveled all over the world and created companies everywhere, and I feel we are not taking enough, support of the talent which is outside US to create better outcomes for patients here.
I think this is going to be very challenging in this COVID climate. It just is, to have patients travel abroad for surgery. I think it's
No, I was not talking about travel abroad. We get through robotic surgery.
products. Yeah,
We get through second opinions.
sure.
Of doing so many things. Because the whole era of using talent from uh, you know even developing countries like India. I think um, which is really good talent which is available. And if we can improve the outcomes and create opportunity for competition and lowering the cost, something which should be very interesting to look at.
Well, I think it'll be interesting. Bharat, I think people are so focused on U.S. trained, and I'll tell you one aspect of our book is very interesting because everyone thinks that Ivy League medical school graduation is the surgeon's got to be great quality, right? There's been no study to show that the surgical outcomes are any different than with somebody who trained at the top of their class or the bottom of their class.
Right.
It's absolutely astonishing, right? But patients do think that, right? So we all put our diplomas up in the waiting room, trying to get patients to understand that, we're a high quality surgeon. But you know what? There's no studies that have shown surgical outcomes are any better with Ivy League trained grads. So, and we've got to look, the training happened 20 years ago. Really, the training happened 20 years ago. The question is, what have you been doing for the last 5 years, right? What kinds of procedures have you been doing the last 5 years? And what are your outcomes in the last 5 years? Forget your training. Your training was a long time ago, right? Have you kept up? That's going to be very important.
Dr. Campbell, I see your hand.
Thanks, doctor.
Sure.
Hey, just an anecdote. I refer people for surgeons a lot, family, friends who call me. One of the best ways you can tell quality of a surgeon in a given institution is talk to an anesthesiologist there. They always know who should do the knee, who should do the neck, who should do the craniotomy, et cetera, who should do the spine. I don't know if there's a way to leverage that, but I know when I'm under the way, if I'm going to a hospital, I need surgery, I call the chief of anesthesia and say, who should I get to do my belly? Just a little anecdote. And I'm wondering, where have you used this so far clinically? And
well, we did this. We did a pilot in the Midwest, in Illinois and Missouri, and that's what. And then COVID happened. All the surgeries went on hold in 20, and in 21 we're just starting to get our feet wet. But we got a big Fortune 50 company with 400,000 lives that's coming aboard. They're very excited about what we're doing, and they love this whole idea about trying to solve racial disparities. And I think that I'll tell you one thing. I don't think there's an employer anywhere in this racially charged environment we're in right now. There's not an employer that's going to say no to our platform.
Well, in spite of that, I mean, realistically, just take that out of the equation. It actually, like we always say, it's kind of forcing the patient to kind of do the best thing that they should have been doing anyway if they went to an unbiased consultant,
right?
As opposed to listening to your broker who's making commission, who's telling you to buy that stock or whatever. Everyone's a winner, and maybe not the people that are benefiting like the insurance company, but to the United States' economy, to that person's life, to their family, they less time in rehab. I mean, you just go down the whole tick list. It's unbelievable. So it's a great conundrum to solve. Get it cash transparency and kind of perfect what you're doing. Man, the world is really bright.
Yeah, and I people always say to me, "Oh, surgeons won't do this. Surgeons won't." You know what? I have yet to meet a surgeon that's not proud of their outcomes. I have yet to meet one. Every surgeon is very proud of their outcomes, of the stuff that they do a lot of, right? And I'll tell you, it's going to help surgeons in the long run. and this is how I'm starting to think, it's going to reduce malpractice risk. Because now you're going to be seeing cases that have already been peer reviewed, right? And all these surgeons have said this patient needs surgery. And I think it's going to reduce your malpractice risk. I think your malpractice premiums are going to go down as well with a platform like this.
I think the malpractice will go down. You have less bad outcomes for the person who needs
Yeah.
that specific surgery, and the guy hasn't done that particular surgery in 2 years, but I'll take a whack at it again. For sure, it makes a huge difference. It's very exciting. And as a prime example where I'm at, I mean, the one major hospital, been around for forever. It's a huge, enormous, like international player. They stuck the liver in the wrong person. Made national news. So now luckily it worked out. It was a match, so that guy's doing well. But the guy who was supposed to get it, he's back on a list. He won't see a liver for 5 to 10 years.
Yeah.
Well, that wasn't a good outcome. So, ideally stuff like that would be found out, or at least you'd figure out. Do you look a little in terms of like the administrative side? Maybe all the doctors are great, but the hospitals not so good in the way they handle claims and all the rest of that part of it?
Jeff, it's going to evolve, right? Right now, we're very focused on surgeon outcomes. Obviously we're interested in
paramount. That's the first part for sure.
We're very, very interested in infection rates at hospitals versus surgery centers. Infection rates are almost zero in a surgery center setting. So there's going to be a lot to be said on that front as well. But it's not the hospital that's operating on the patient, right? It's the surgeon. And the surgeon is the one who's making the decision, right, on whether to operate, when not to operate. What are the preoperative consults that you need, et cetera. I mean, it's the surgeon that's just making the decision. It's a surgeon that's doing the surgery. It's a surgeon that's directing the postoperative care. So, you have to point to the surgeon when it comes to outcomes.
Fair enough. All right. Well, on that note, I have time for one last question here, and then we're going to let the doctor scoot. Anybody have any comments? Well, as we're waiting to see, again, in the chat, there's the email. You certainly can go ahead and order up a nice complimentary copy, and I certainly appreciate you doing that for our audience. And then at the same time, I want to let you know that we will have this up and running, like I said, over the weekend. Please share readily. We'd definitely like to get as much viewership. We get a lot more play in the reruns because we're on those different platforms. So, Doc, I want to tell you thank you for today.
Great. Thank you. It's a pleasure, and it's a pleasure to meet everyone as well.